My name is Xaher Gul. I'm the Senior Advisor for Social and Behavior Change in Health Markets with Pathfinder International, and I am based in Karachi. My journey to this role began 22 years ago when I graduated from med school in 1999. I was all of 24 years old, and I truly believe that I now possess all that is sacred and holy to help people. I would spend about 15 minutes with my patients in which I would take a detailed history, do an examination, prescribe treatment, and then whatever was left or over, maybe about a minute or so, I would spend counseling them on how to help themselves stay healthy. More often than not, when they came back, they would have not done what they were counseled to do, but that was okay because that's what patients did. And we were never trained to think that it was our job to help them achieve those changes that need to be achieved. It wasn't until I shifted from clinical medicine to public health and started working as a health manager, looking after programs delivering primary health care and emergency services in humanitarian and crisis-affected settings, that my paradigm shifted. I was looking at numbers coming in from the programs regarding service uptake. No matter what we did, the service numbers were always low. They were far below what we would project. And even though services were available, they were free of cost. Women wouldn't come in for antenatal checkups. They wouldn't come in for contraception. Families wouldn't bring children in for immunization or growth monitoring. And this with outreach health workers going door to counsel families on what would be healthy for them and their families. I was coming from a very strong biomedical paradigm where people were patients who needed to be told what to do and saved as passive recipients of care. I'd heard of terms like community mobilization and behavior change communication, but this was technical jargon predominantly relegated to technical proposals and reports with very little bearing on what we did on ground in the real world. This made me curious about why these terms were there, and during my journey of discovery, I was introduced by one of my mentors to the works of the Brazilian educator and philosopher Paulo Freire. And in his very powerful book, Pedagogy of the Oppressed, he states something which has stayed with me as my guiding beacon through all these years. Freire states that nobody is a blank slate. Individuals are shaped by their experiences and impressions, and that women and men can learn through learning that they can make and remake themselves. That women and men are individuals capable of taking responsibility for themselves as beings capable of knowing that they do, and also knowing that they do not. This started a strong paradigm shift for me, which is continuing to evolve even today. And I realized with some restrained horror that I had spent the better part of a decade talking at people, throwing information at them, being paternalistic about what they should be doing for themselves. It eventually led me to try to figure out what makes people learn to make or remake themselves. How do we understand and facilitate people in understanding what they know or do not know? And how do we facilitate individuals and groups of people to expand critical thought and be able to shape and reshape their lives? And the answer to that I found when I discovered behavior theory. Behavior theory bridges the gap between psychology and the more systems-oriented public health programs. Psychology has shown a heavy reliance on theory to explain human behavior and individual perceptions amongst people. This notion is considered too technical, too resource intensive, too time consuming for public health programs to be of any practical significance at the field level. So much so that there has existed a tangible divide between organizations that identify as service delivery organizations and organizations which identify as social and behavior change or SBC organizations. But these are exciting times. A paradigm shift is taking place, and times are changing. What I love about working at Pathfinder is that despite being a systems-oriented, conventional service delivery organization for SRHR, our vision is driven by an unwavering belief in the inherent agency of our right holders. Organizationally, we understand that it is not simply enough to strengthen systems or build facilities. Our programs, if they mean to deliver impact, must engage with individuals and groups of individuals in their communities and be able to identify, understand, and empathize with individual perceptions of how they think and feel, how they see the world, and perceive themselves in it. This allows our programs to be person-centered and operate at that person-centered level. But this is potentially very complex because no two individuals are alike. No two groups of individuals are the same. So how do our programs deliver messages, design interventions, and engage with communities in a meaningful manner where they respond to all individuals represented within those groups? This is where behavior theory and psychology comes in and allows us to focus on what is common and what may be different across individuals. The idea of theory isn't a new one. The earliest discourse on human nature describing why people act the way they do was put forth by the 11th century scholar Al-Ghazali. He presented a framework which described three drivers for human behavior. According to Ghazali, if somebody has the right knowledge for an action, if they have favorable feelings towards that behavior, in that it doesn't produce fear or anxiety, and if they have volitional control over that behavior, they will go on to develop intention for that behavior. And Ghazali described intention as the primary driver for all human behavior. This was proposed in the 11th century, and it wasn't until 1,000 years later that Fishbein and Eisen came and presented their theory of reasoned action and planned behavior, which describes intention as the primary driver of human behavior, with similar concepts driving intention as those described by Al-Ghazali's framework. This and other behavior theories are the only tool at our disposal to understand what needs to change to drive behavior change, to identify what interventions may be needed, how they should be delivered, and to whom. However, public health practitioners still feel challenged by several of these theoretical concepts within behavior change theory, which are perceived to be sometimes too soft and mushy or granular to be able to be of any practical significance in public health programs. It is deemed by certain scholars to be too Western to be of relevance to the operating context of Eastern cultures. However, there's a plethora of evidence where the same theory has been applied for similar behaviors across different cultural contexts and has been applied successfully and efficiently. These theories provide programs with a common lens through which they can view the audiences that they engage with, the services that they deliver, and the associated beliefs, perceptions, and values that need to be encouraged to increase the adoption of life-saving behaviors. These theories also help us understand what needs to change, how an intervention should be designed, and how to measure the impact of these interventions on individual beliefs and perceptions underlying a particular behavior. This integrated SPC framework tells us that our programs must operate at multiple levels of influence to shift strongly interconnected behaviors of multiple actors at different levels of influence. This framework also tells us that where our programs need to shift attitudes, we must focus on how people feel about a behavior in addition to what they think about a behavior. Our programs must focus on building personal agency amongst girls and women, boys and men, so that they are able to access the services we are supporting. Scholarship on SBC indicates that attitudes and personal agency are strongly influenced by perceptions of norms and existing social norms within a community. And shifting social norms can be very challenging, but also downright dangerous at times. This is where theory helps us. It guides us that it is not the actual collective social norms that we must shift. It is the individual's perceptions of these social norms. Specifically, whether the behavior in question is likely in their community, is it a common behavior, and whether it is socially approved. And that is what our programs must focus on for shifting social norms. Finally, this framework also tells us how to engage with groups of people in a community to help them to develop collective efficacy, community capacity, and build social capital to shape and reshape their own lives. And we bring all of these different imperatives together within one integrated framework for SBC at Pathfinder. And this is where it gets really fun and exciting, because the same framework can help us design and deliver programming to support a multitude of domains within healthcare and within SRHR. For example, the framework has helped us deliver couple-focused family planning intervention at the community level in India through the Project Yuva. So this entire ramble was aimed at answering one question: why use theory for social and behavior change or SBC programming? Without behavior theory, programming is akin to throwing a dart at a board which is moving with the blindfold on. In real-world settings, there's very little we can do about the dart or the moving board, but we can certainly take the blindfold off.